Welcome everyone to today's webinar sponsored by Ludi. I am Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. John Guidati is the Vice President of Acute Care Compliance for AMITA Health, one of the largest hospital systems in Illinois. John has over 30 years of experience in several areas of executive management, including compliance, internal audit, safety, security, and privacy. Prior to joining AMITA Health, John served as the Director of Corporate Compliance and Internal Audit for Silver Cross Hospital in Illinois. Neely Debade is the Vice President of Organizational Development and Chief Learning Officer at Western Reserve Hospital, a physician-owned hospital in Northeast Ohio. Neely has extensive experience in the hospital and healthcare industry. Prior to joining Western Reserve, she was part of South Point Hospital in Ohio. Opal Greenway is a director and healthcare consultant for Stroudwater Associates, a national healthcare consulting firm serving healthcare clients exclusively. Opal is an expert in valuations, mergers and acquisitions, strategy, physician compensation, and regulatory compliance. Gail Peace is the founder and CEO of Ludi, a healthcare technology and physician advocacy firm based in Nashville. Prior to founding Ludi in 2012, she served as Vice President for Business Development at Vanguard Health Chicago, which was acquired by Tenet. Gail has also served in leadership roles at WebMD, McNeil Hospital, and Saks Group, which is now Truven Health. At this time, I am pleased to turn the floor over to Gail to begin today's presentation.
Thank you, Mackenzie, and welcome everybody to our discussion today. As your host, I wanted to start with just a quick sentence about who Ludi is and what we do. We are a healthcare technology and physician advocacy firm, and we really simplify the way hospitals pay physicians. So any contract you have that you need to pay a physician, we work in that space with automation. For today's agenda, we have 4 different things we'd like to cover. First, I'll begin with just a few minutes to level set the relationship between the hospital and the physician. Then I'll turn it over to Opal, who's going to talk about compensation, both pitfalls and also some best practices for us. And then we'll turn it to John and Neely, and we're going to hear their individual stories about how they've tackled this very complex issue at their facilities. And then we'll open it to the floor for Q&A. So I'll remind you when we get to that point, but on the left side of your screen, there's a Q&A button, and you can submit questions at any time. If you have a particular person you want to answer it, let us know that. Otherwise, we'll direct it at who we think is probably best served to start. So a little bit about the physician-hospital relationship. Basically, anytime you pay a doctor, you're aligned. So if you pay a physician to be a medical director, that's a basic sort of alignment. If you employ the physician, you're more aligned because you're capturing all of their business. So if we stop for a minute and think about all of the reasons we pay physicians, essentially we're trying to make sure we serve our patients in the most cost-effective, high-quality route that we can take. So these relationships and this alignment we have with doctors is to further the patient agenda. When we hire the doctors, an interesting thing that happens is that why does this matter? Really, the amount we spend on all of these things, on all types of alignment, is actually pretty astounding. And I have the opportunity to travel around the country quite a bit, and I frequently sit with CEOs or CFOs who want to argue with this number when I say it's rapidly approaching 10% of your net patient revenue, your physician spend. And I think it's because in our current financial systems, we can't look in any one place and see what our physician spend is. It sits in payroll, which is fairly easy to capture, and then it sits in 95 other places in the general ledger on the accounts payable side. So what's really interesting to me is that this number is growing at a big rate, and I think many hospitals have woken up either intended or not, and they're running enormous physician enterprises. And they come with enough challenges and certainly fraught with a lot of interesting dynamics. So what we like to talk about today, what we'd like to talk about is all of the cooks in the kitchen. And if all we really want is what's best for the patient, it's really what's best for the doctor, right, in our alignment strategy. So as you think about all of the cooks, we've got business development who's saying we need to grow our volume, we need to hire 5 doctors. We've got finance who, let's face it, never really wants to pay for anything. And I say that very fondly as a business owner myself. Unless the ROI is there, you want to see it. And sometimes with these physician investments, there's a ramp time until we see that value. We've got compliance and legal protecting us on the structure of that arrangement. We've got HR that helps onboard in whatever the relationship is. And then we have the physician enterprise. And we see about half the hospitals in the country have a defined physician enterprise, and that may only mean the employed doctors. So you're ignoring the other half that are independent in that enterprise, if you will. So really, there's a lot of cooks in the kitchen from the standpoint of when we set these agreements up, and they also each kind of enter with a different thing in their mind. But every time we invest in our doctors, it means we're not investing in something else. So think about that for a minute. When you spend 10% of your NPR on your physician enterprise, then there's less money available for equipment, for other resources. This is actually a picture that John will recognize of one of the AMITA facilities in Chicagoland. You know, we have very large, expensive plants that we're operating that have requirements, capital requirements. So it's always important to remember when we invest in our doctors and in that enterprise, we're foregoing something else. So I'm going to share with you a story I have related to conflict with all these internal shareholders. It's very personal. When I was working in the Chicago market, I was doing the strategic plans for all 4 of our facilities. And on our western border, we had the desire, it was a very favorable market, very nice payer mix, high growth area. We wanted to try to pull more patients from that area. So we decided to start with placing some primary care hubs. So we intended to do 3 hubs in 1 year. And so as a development person, I estimated the cost of each of these investments. We did a business plan. And what happened was that, as frequently happens, it's hard to recruit the doctors. The build out on the first facility was slower than we would have hoped. And so we really took the first year to only open 1. Now, it was a really successful center. We had 2 primary care physicians that were already in market. We relocated, and we built another 4 around them with some integrated pieces. We had lab, we had x-ray. So it was a really nice center, but we had 1 center at the end of the day. So if you look at how we judged how we did on that strategy, you know, the CFO may say it was terrible. We only opened 1 facility. Whereas the person running the physician enterprise said, we have 6 very successful physicians. This is a great outcome. So people have conflicting views from their respective departments. So here's where I see alignment being off with the physicians and the different stakeholders. So the first is when maybe you're not even measuring it. It's oddly hard to get your hands around this data. If you have your payroll number where you know what you're spending, maybe your pathology agreement, your ER agreement, some of your big hospital-based PSAs sit over in accounts payable. Then we have, maybe in the medical staff office, we have a list of committee chairs. We have over in the ER the folks that we contract with for on-call. So sometimes it's just a matter of getting your hands around the data in order to be able to measure. But best practice is really to define at the start of the relationship, how are we going to measure what's working and what's not. You also might have the wrong deal. It could be the wrong doctor. It could be the wrong time frame. It could be the wrong person setting it up. All of these things can create failure on that relationship. And another reason might be what I shared on the last slide, which is you don't implement it fully. So some may say we're not being successful. We didn't hit our volume number. Well, we hired 1/3 of the physicians that we intended to. Maybe your assumptions were wrong, either with timing or with the volume growth expectations. So essentially, you know, the goal of this alignment is to have the doctor feel like they really own it and they're part of of your business, and that all of the shareholders who were part of this agreement at the beginning have a sense of how we measure and how we grade ourselves. So going back to the cooks in the kitchen analogy, I don't know if anybody here has worked in a restaurant, and I mean, I'm not Gordon Ramsay. I've worked in one before, but each person in that kitchen has a specific job. And if there is not an executive chef, chaos ensues, right? If the person working on salad also decides, well, I want to do bread tonight, or I'm going to go make a dessert. If the person doing the entree is not solely focused on that, but decides, hey, I'm going to go work on this appetizer, things won't get done. And so I think bringing together your physician alignment strategy, what we see as best practice is when there is an owner of this whole physician strategy. And so I don't know if that's the business development person, the physician enterprise leader, if it's a finance leader at your organization. I don't think there's necessarily a right answer on who owns it, but identifying one person to really be the lead over not just setting these up, but managing them. So each year you should really evaluate each contract in the context of that unique deal. Do we still need it? Did it do what we wanted it to do? Is it the right doctor? Is it the right location? Is it the right deal? And, you know, at the onset, if you have some time to really think about what are our key performance indicators in this particular strategy, it makes it easier. But I think, you know, bringing people together is the first step. And the next step is to really have data, right? So if you want to measure where you are, you need to have a dashboard. And so if you have data in disparate manual systems, if it is not automated, you are way behind the 8 ball on being able to measure if, in fact, things are working. So, you know, our advice would be to figure out who owns this, who's riding herd over it, so who's, I don't know, use executive chef or the captain of the plane, who's really in charge, and then they're going to need data, information, and people to evaluate and keep measuring what we're doing. And I think, you know, there's no right answer on any of this, but where we see hospitals being successful today is when they stop and they say, wait a minute, we've got 10% of our net patient revenues tied up in our physician enterprise. Where's our return on investment? Are we spending in that in the best way that we can? And the answer to that question today is very different than it'll be next week. It's a moving target, so it requires certainly a lot of discipline. So with that, I'm going to turn the floor over to my colleague, Opal.
Thank you, Gail. So we're going to start off talking about some of the compensation pitfalls that I've seen with my various travels and working with several different hospitals, health systems, and physician groups. So one of the big things that we see as a top mistake in physician compensation, which I know may be surprising to some, and I will say it breaks my lawyer heart every single time I see this, where the actual contract's not in writing. You might have a legacy agreement, or the contract that is in writing has been outdated, was never renewed, it doesn't have an evergreen clause in it, and so the contract truly doesn't even matter. I know that's shocking to some people, but I see it on a regular basis and at hospitals of all sizes. It is not just a critical access hospital in Iowa that doesn't have a written agreement. I've seen it in hospitals that are in, you know, Memphis and Miami and those different areas as well that don't have a written agreement or don't have a current written agreement. On top of that, I see no way of people tracking their contracts, where you know that, as Gail was talking about with the too many cooks analogy, contracts might sit in one department, but the contracts are being negotiated by the Vice President of Physician Affairs or the CEO for that matter. And you never know when the contract's due for negotiation. When is it up for renewal? What are the terms? When was the last time we looked at it? I was recently in a hospital health system in Texas, and they hadn't looked at their physician contracts in 5 years, and part of it was the assumption that, well, we have strong alignment with the physicians, everybody's happy, why should we look at this? Well, I was brought in because they were seeing losses in the physician clinics and were wondering why, and the first thing I always ask for is, well, how are you paying your docs? And somebody assumed they summarized it. I ask, let me see the contracts, and the contracts and what they think they're doing are not the same. Then I go and talk to payroll and what they're tracking, and it's not the same. And I talk to the physicians, and the physicians aren't in agreement. So we have three different sides, all saying different things about compensation, and oftentimes it's one of the largest contributors to physician practice losses is not knowing what's going on with those contracts and those compensation. On top of that, we're seeing contracts and what is available to people under Stark and anti-kickback laws that is going to be compliant is ever changing. And so when you have an inconsistency amongst how you pay your different specialists, especially if you might start out with one orthopedic group and then start employing some additional ones, and you have a lot of inconsistency in how you pay them, it becomes all that much more difficult to track how you're doing those payments and is it fair. And guess what? Physicians talk. They talk to one another. They talk about what they make. And in doing so, you are actually destroying your physician-hospital alignment and that overall relationship, because now there's a lack of trust when people feel like maybe I'm the one who's not being treated fairly. As Gail already mentioned, I also see that a lot of times the professional services agreements aren't tracked, right? And that could be everything from your pathologist to your anesthesiologist or your emergency medicine physicians. Those are very commonly outsourced services, and they might sit over on, when I look at my P&L, they may sit under professional fees or contract services, not under salaries and benefits where my other physicians are. So do you really know what your physician spend is if it's tracked in all these different places? And the number one thing that I actually see as a mistake is there is no strategy behind it. No, you don't step back and think overall, what are we trying to accomplish here, And when we think about that, what we're trying to accomplish, what is the ROI it's going to generate? Because if we're going to spend the money here, we're not spending it elsewhere. And then stepping back, say, okay, as an enterprise, if this is our strategy, what's the compensation strategy that will actually support that? Is this compensation strategy going to get us to where we know? Is it flexible enough to move with the times? I'm one of those people who says don't pay for something that you don't get paid for. So if your reimbursement is up for changes, whether it's part of an ACO or value-based, is your compensation strategy something that can adjust with that? So I have to highlight the different compensation models that we see, because all of these things are the kinds of things that I see that are tracked in different departments. So you have your individual contracts with the physician. It might be an employment. It might be a direct compensation or a PSA with one individual physician. You may have a group model where you're contracted, and oftentimes this is more frequent with a PSA model where an entire group is being tracked. And that contract might have several different components where somebody in that group is your medical director or might be doing co-management agreement with them. That own group might figure out how they distribute things differently amongst their group based off of the productivity. So they need data from you to be able to distribute within their own PSA. And being a good hospital partner, being able to get them that data, even though some people I work with have said, well, that's the group's problem for them to track. But if the hospital is the keeper of the data, the physician group is heavily reliant on you. On top of that, you have stacking compensation issues, which is oftentimes some of the things that I see that gets you into a Stark and anti-kickback statute problems, where you have maybe a call coverage agreement or a medical directorship, or maybe you have a co-management service line agreement, or you have another agreement for APP supervision, or if you have residents in your hospital and you have teaching agreements in there. And each one of these agreements oftentimes sits in a different department. So even if you're really great about all your employed physicians are sitting in one location, these other contracts oftentimes are managed by somebody else. And so we really do have that issue of too many cooks who actually also have similar jobs, but no coordination amongst them. With that, we also have the added complexity of different types of compensation model. There's the most simple way, which is an annual guarantee where it's a base salary. But even that should be tracked for understanding what's the ROI we're getting off of that annual guarantee. Does it make sense, and does it incentivize the behavior and the alignment strategy that we as an organization want? Less common is a percentage of net patient service revenue. That there is an obvious one of needing to be able to make sure, are you getting an ROI on that? Most common now is paying based off of productivity, doing some sort of compensation per work RVU model. But here you still have the complexity of maybe your billing has been outsourced. Is the billing department tracking work RVUs correctly? What if your contract requires some sort of reconciliation between the draw that is paid out to the physician monthly and then you do a quarterly reconciliation? So is that being tracked appropriately? Then we have, as I mentioned earlier, the fact that we are having significant changes in reimbursement. So if we have value-based compensation, and we're not just talking about, yes, quality has been a big one. A lot of people are very familiar with PQRS and have put in some sort of maybe a 10% bump for the physician if they hit certain quality metrics. But what about the fact that if you're in a part of an ACO or you've done Medicare shared savings, how are you distributing those dollars across the enterprise? Do the physicians get any of that? How do you do it in a way that drives your alignment but also is compliant with Stark and anti-kickback regulations? So that being said, right, the execution. What is the physician compensation on that number? As opposed to, you can see here on the slide, the contracts have all these different places, and I can tell you that number on the P&L rarely actually incorporates all of these different pieces. So that being said, we know that this is the largest ticket item for hospitals and what they're spending. It has several different components. Right, being able to track the ROI if you don't know what numbers are going to be in your numerators and denominators, how do you really actually know that you're getting that return, especially when we add the complexity of what's the downstream revenue. That's how we're calculating our ROI usually for employed physicians, is we accept a loss in the physician clinics and we assume that the downstream, the ancillaries, et cetera, is what's covering it. If you don't know what you're spending, how do you know that that downstream revenue is covering it? I will go ahead and point out another little issue that I do see come up frequently is when you try to track it under contract labor and professional fees, your physician services are a distinct difference, right? You have alignment issues there. So even if most of your contract labor is, say, your locums agreements, each one of these is part of the alignment strategy for your physicians, and knowing that is what is going to make your hospital and health system successful. With that, where does this execution fail with all this complexity? Where I see it fail the most is the lack of coordination and communication. We have all these different departments that are handling money that goes out to physicians and also determines the information that is coming in that determines what money does go out. And so if any one of these parts fail, you didn't have a proper valuation done, you don't have the physician contract, you don't have the contract being executed the way that it was written, you make a change and physician negotiates a change to their contract with the CEO, but payroll is not alerted, right? Now you have a physician who's received compensation that varies from what they expected, and you have a very unhappy physician. And then on top of that, whether or not you can actually trust the data that you're looking at, or is it being documented properly? One of the biggest things I see is medical directorships. They have documentation requirements that are oftentimes these sad paper, handwritten notes of this is how I spent my time. If you even have a timesheet, the timesheets are absolutely required legally, but this piece of paper that nobody can track down and is illegible and we just assume it so we pay it out. Are we actually getting an ROI for those different services? I will underline that this is a significant issue, right? The cost of compliance is huge. And so here are some headlines that we've seen as to what happens with this, and they're significant whether or not, I'm not in the tax bracket where a $4.1 million penalty means nothing to me. I don't know how many of you are in that tax bracket where that penalty doesn't mean anything to you, but I've worked with several hospitals that kind of penalty can close their doors. And it doesn't have to just be the big scary numbers, right, of $84.5 million, because remember, this isn't an intent-based thing. You can just, if you pay improperly against the statute, you can be in trouble. It doesn't matter. But on top of that, not just the legal cost of compliance, one thing I'll highlight is it's the trust relationship with your physicians. I recently worked with a group where the contract was not, the contract requirements were based off of a compensation per work RVU. The valuation had a cap in it, and they didn't match. So something's sitting over in legal, something is sitting in payroll. They paid out a highly productive physician, fantastic cardiologist. They overpaid by over $600,000 compared to what was in the valuation. Legally, they owed that physician the money. It matched his contract. Payroll paid him as they were supposed to. But now it was against their valuation, and the OIG was going to come knocking. And so they needed to ask the physician to actually pay some of that money back, and they had to do self-reporting. Imagine the damage that did to the relationship with the hospital and the physician to ask a physician who is one of your top performers, you need to pay back $600,000 that we've paid you over the past year. That's in a single year. So as I said, a very highly productive physician. And we went through and searched, audited all of the claims, making sure everything about it was true. It took 6 months just to start really repairing that relationship. And I can say I don't think that the hospital and the physician will ever be back to the terms that they were prior to this. And so forget even the Medicare compliance aspect that they had to deal with, but that relationship with the physician is also well known across all the medical enterprise there in the community. So before I hand it over to John, I will just go ahead and say some best practices. Make sure you have a compensation strategy that fits and actually incentivizes what the strategy of your organization is. What are you trying to achieve, and does your compensation actually move you forward on that? Don't pay for anything that you don't get paid for. So is it in line with your reimbursement? Make sure you know where all these different buckets sit, know who the different cooks are, right? Who negotiates the contract? Is it the Vice President of Medical Affairs? Is it the CEO? Is it your controller? Who's taking that lead for it? And make sure that there's coordination amongst all the different departments that don't touch it. Don't forget that your billing and revenue cycle impacts your physician spend. So are they included in it? And make sure you have the data at your fingertips. Being able, when I go into an engagement and get called in, and it takes 5 months to get the data, I can tell you right now that is an organization that has no idea what their physician spend is, and I can promise you has not been getting the ROI that they could or should have been doing for years if it takes that long to be able to pull the data. So with that being said, I'll go ahead and turn it over to John, who is going to talk a little bit about his specific instances and experiences.
All right. Thanks, Opal. Good afternoon, everybody. Just a quick little background on AMITA Health. I've been here 4.5 years, and in that 4.5 years, as you can imagine, in healthcare, there's been many changes. 4.5 years ago, I came in when the joint operating agreement was made between Adventist Health Midwest and Alexian Brothers / Ascension. So since then, we've, in March of 2008, had Presence Health join the Ascension Group, and with that, we added quite a few more facilities with our system. And again, with that, we had several physician agreements that we had the task to find out how are we paying those, what system are we currently using, how are we looking at them, and what can we do to improve our process. I had the pleasure 4 years ago working with the integration of Adventist into the DocTime system, and now we've been working since mid-2019 on the Presence project and integrating those 9 facilities and the various physician agreements into the system. And it's been quite a project, and we're continuing to work on it. So, as Opal said earlier, her slide 14, she talked about the top mistakes in physician compensation, and certainly we, in our compliance world, are always concerned about stark violations, anti-kickback, false claims acts, and in physician compensation, certainly there's many risks with that. If we have a physician we're paying without an agreement, or they're leasing space and not paying on that agreement, and so on. One thing we want to avoid is having to self-disclose and pay back Medicare, Medicaid claims, but the reality is if we do find that we have to self-disclose, typically then there will be a fine and a repayment made at that time. So that's certainly one of the goals, is to avoid that. AMITA Health, we've had a history of focusing on doing the right thing with physician arrangements. There has been a standardization of contracting and work with our legal team and with our compliance team, and of course the contract owners to standardize that. That happened many years ago. We also have a software system where we manage these contracts, and that helps quite a bit to be able to really gather that information on the contract management system itself. But the part that we were really missing was actually looking at this data and quantifying it and taking a deeper dive and closer look into what that physician compensation is, and making sure that we follow our contract terms and we follow it in a compliant manner. So there's many functions that we have, working with our finance group, working with our AP, our payroll, trying to figure out who is paid independently, who is paid as an employee. A lot of different challenges when it comes to the reimbursement of our physicians. So we flip to the next slide here and go in a little bit more detail. And again, this is probably the best experience we've had recently is with the President's Experience, most recent one with the new acquisition, which really caused us to take a look at the contracts that were in place, and there were several hundred of those, and how they were being managed through the system at the time. And it was really a manual process of really making sure that the payments aligned with the contract terms. And with the DocTime system now, we're able to electronically be able to gather information we need to. And it's helped quite a bit so we can avoid any kind of conflicts. And it's been really, as the slide says, a trusted source of data for our organization. And we share that data with many departments: strategic planning, our CMOs, performance improvement. I actually had a call this morning from a regional CFO who was concerned about an approval of a physician's payment that seemed to be late, put in late. And I was able to work with our legal department and go into the system and validate for that CFO that, yes, we do have a current contract in place, so we can go ahead and pay. And I was able to produce a report out of the system to show the historical data of what that physician's been paid for the past several months. And with that information, he went ahead and approved it. So it made it very quick and easy for us to be able to do that. We've standardized the templates, the process. The physicians and staff are fully engaged in this. We've integrated administrative contracts, be it a medical director, on-call contracts, teaching. We're finding that we want to pay through DocTime anything that quite fits into this category. It may not be an exclusive PSA agreement where it's invoiced on an annual basis, but anything we can put an hourly payment to and pay it on a monthly basis, we want to be able to do that. And again, that's to quantify the physician compensation that is actually going to our physicians, and to be able to show how much is being spent regarding that too. The biggest surprise probably is that, we've had to engage a lot of different players when it comes to this, but the physicians have been, in my experience, the easiest ones to deal with. They really want to get away from turning in paper timesheets, paper logs. They want to be able to modernize it, and with the system now, they're able to utilize their phone via an app, their computer, and plug in the monthly information they need to be able to then produce that report over to our hospital leaders to approve, and then from there it'll go through our finance department for final payment. It's been very beneficial to them. They worry at first, how are we going to learn this? Not quite understanding it. But once they see it, they really feel it is so easy to use, and they end up being probably our best champions when it comes to why we're doing it and the benefits of using an automated system like what we are doing now. With that, I think I will turn it over to Neely.
Thanks, John. Hi, everyone. I'm Neely Debate from Western Reserve Hospital in Ohio, and I've been with Western Reserve for 10 years. We are Northeast Ohio's first physician-owned for-profit full-service hospital. located just outside of Akron, Ohio, in Cuyahoga Falls. And we are owned by more than 175 physician partners. And we were looking to streamline our processes around physician time tracking for the very reasons that both Gail and Opal and even John have, commented on, for the simple fact that all of these contracts lived in different places. Tracking them on paper required a lot of work with our finance team when we wanted to create reports or file our cost report. So we were looking for a solution to help us in that way. As a physician-owned hospital, we really had highly engaged physicians who understood the operations of the organization. They absolutely wanted to ensure compliance. They were aware of all of the varieties of contracts. We had employment contracts, teaching contracts, administrative contracts. We literally, again, had them spread across the organization, and we were looking for a way to also simplify the physician's submission of time. I talk about chasing paper and how often we would know that the timesheets were due on a certain day of the month, and then we would spend the next 2 or 3 days tracking down the people who needed to be turning those sheets in, carrying around copies of the timesheet on paper, trying to get them to fill them out. They would be looking back through their phone to fill out the corresponding calendar, and one of the things the app does is allow them to do that in real time on the fly now, which has been a great streamlining process. We do have a number of educationally focused programs. Our residency education programs each have a physician program director. We also have some faculty who are compensated. So we really did have a strong desire to streamline our payment processes. We chose Ludi because of the digital hub in DocTime log, and it allowed us to see very quickly as we got those contracts entered how to standardize payment and start to refine the duties for each of the positions that we were entering in the system. It's made it so much easier for us to gather data, make payments to physicians, audit the time by duties, submit our Medicare cost report, and for me, budgeting is so much easier to look at the actual spend over the prior year, and it certainly makes contract negotiations a little more black and white because we have data to share with the physician. Often we can show that while, the hours might need adjusted, or perhaps the max amount of the contract might need adjusted because we have data now. We've been able to standardize our agreements and watch for potential errors. I think the best practice, one of the things that we have learned is that we can learn from one another. When one of us who administers a contract has an issue, we can share that with everyone and point out how the contracts need to be changed and or cleaned up. It also required us to fine-tune duties, and we have worked, it was interesting, with some of the medical directorships. Every medical directorship contract had different duties outlined, and so we were able to make those more consistent and focus on what we actually wanted to be compensating the physicians to do. It also allowed the physicians to focus on what they needed to and not worry about, accurately selecting the duty from what was listed in the contract to a timesheet interpretation, because a lot of the categories on the timesheet did not align with the duties that were in the contract. And now with the digital system, the duties are the timesheet. And that's made it much easier for physicians to enter their time, and they can do it while they're sitting in the meeting from their phone on an app, and they all have really appreciated the simplicity of that. They don't have to worry about scanning and faxing timesheets to us. They really do understand also what they're being paid for. We were able to, explain to them the categories of the contract and the duties as they're entered in Doc Time Log, and that just increased accountability for everyone. And essentially, I think the one thing that it did was make sure that we are very aligned with our physicians. Our CEO was clear as to why we were choosing a digital time solution in Doc Time, and the benefits that it provided not just to the organization but also to the physician. And as a result, we really have we've had no friction at all. Everyone has willingly participated in the digital time system. So with that, I'm going to turn it over to Gail.
Thank you, Neely. That was great, and thank you, John, for sharing your stories. We're going to go ahead and open it up to questions, and we see a handful coming in, so thank you all for submitting. And let me just say, if we don't get to your question, we will answer it electronically back to you. For some of the more product-specific, we may do some of that electronically later. But let me start by first directing one to John. And, John, you mentioned during your discussion that physician contracts are certainly a top area of concern. And you mentioned a little bit about the laws, but what are the highest levels of risk, do you think, from a hospital perspective in the compliance world?
Well, as many of you might know, the Stark Law is not intent-based, and if you accidentally pay a physician incorrectly, you could have a violation. The settlements can be millions of dollars and more than likely can lead to a self-disclosure. So certainly you want to avoid that at all costs. And physician contracts are a key area of risk when it comes to potentially having a violation. As I stated earlier, you have to make sure you have everything in place to justify the payment, a current agreement, the terms of the agreement, fair market value, and so on. And we have run into issues and noticed issues where maybe we didn't comply as we should, and so we have the obligation to make that self-disclosure, which we'll do. It's nothing a CFO or a CEO wants to hear happen, or a legal department, but it's a reality, so we want to avoid that at all times. One of the things that we want to make sure that, we check against every contract that payment to make sure it matches up. Things can be easily missed, and with the system, we put in parameters in that system to hopefully avoid any overpayments to the physician, that if they hit their max for the year, they're not going to get paid any longer than that if the contract expires, they won't receive payment until that contract is amended and extended. So a lot of different things can get tied into it, Gail.
Perfect. So one thing this is Opal from Stroudwater, one thing I'd like to add to what John said is with the Stark and anti-kickback piece, a lot of people focus on fair market value and they think that if they have a valuation report sitting in a desk somewhere, they're fine. One of the key pieces of it is the commercial reasonableness, so that you can justify, so not only can you hand over the materials to say, here's what we spend, can you justify how that fits in? And so not just having the data, but constantly coming back to how does this fit into your strategy, and being able to show why it was a good decision and the commercial reasonableness behind it is a key element of this compliance that I think a lot of people miss, and part of it is because they don't have the data to be able to track that appropriately.
Perfect. Thanks, Opal. Well, I have to flip it to Neely for a second, because if you stop and think about Neely's role being at a physician-owned hospital, boy, you have alignment in a different way than many of us see. The physicians they own the hospital, they run the hospital, they work with you. So starting with that in mind, kind of building on what John said, as you've changed how you're making payments to doctors, have you run into any resistance from your physician enterprise? I mean, John said it was pretty easy to get the physicians on board. What is your experience?
Yeah, no, we have not run into resistance. Our culture is one of compliance and doing the right thing. And once our CEO established the rationale for this initiative, Our physicians knew that in addition to protecting the organization, it protected them as well. We just moved forward with implementation. There was really no pushback at all, Gail.
That's interesting. So, Opal, I'm struck with wondering, are John and Neely just in organizations that recognize compliance and not have that friction between the different departments? Because, they kind of decided they were going to go solve this. So in your travels, where do you see most hospitals getting hung up with all the cooks in the kitchen when they're setting up these deals?
I would have to say, Gail, that it's around the coordination. It's not that people don't care about compliance. I think every organization I've been to cares about compliance, but that whether it's culturally within the organization or just a matter of that communication and coordination, where compliance ends up, if it's not quality compliance for the safety of the patient, it gets put down as a bottom of something that they need to check a box on. So they'll just get the evaluation report and say, okay, that's it. We don't need to be worried about it anymore because there's all these other different moving pieces. And so I bring it back to overall, what is the strategy of the organization, and does all of our moving parts and that coordination support the strategy of and the mission of the overall system? And changing your mindset, instead of thinking of this as just a compliance box, thinking about that compensation strategy. And now you'll have actually an organization that will be focusing on how do we have all these cooks, and how do we actually coordinate them in a way that makes sense? Because you can't eliminate the fact that you're going to have payroll involved, you're going to have legal involved, you're going to have the physician affairs person involved, you're going to have the physicians themselves involved in it, and billing companies. And so if everybody's on the board with the overall mission and the strategy of the organization, tying that in to it will help have this coordination amongst everybody else who needs to share the information and make sure, are we rowing in the same direction?
Okay, perfect. Switching gears a little bit, I don't know if this is common. I'm curious for John and Neely. I'll start first with John. If your board has a physician compensation committee that reviews specific compensation from the doctors. How involved is your board in this today compared to 5 years ago, maybe? I'll start with John.
Well, yeah, absolutely. It's their responsibility. And one of the things that we have found that with physician compensation and the board, it gets a lot to the reporting and how we get that information to them and how we get it in a concise manner, in a concise report. We're able to do that now itself and give them real-time data from our hospitals on how that information is now tracked and how accurate it is, probably better than ever.
Excellent. And what about you, Neely? Are you reporting to a compensation committee as well at the board level?
Yes, our Board of Managers actually does review all physician compensation, and I do think that the reports that we're able to produce provide more streamlined data. It's much easier to look at the analytics and not, have to look at multiple sources of input to be able to make a decision relative to the compensation.
Okay, awesome.
Gail, if I can just interject one more thing, because I think this is important that, as we look at the contracts now, we really take a deeper dive and closer look. Is there, when we talk about money and spending with our finance folks, is there a need for this service still? And is there a need for this on-call contract or not? And I think that's one of the big benefits that we've seen the past couple of years with getting our CMO involved in it and some of the performance improvement folks is to really open up some eyes to see what we're spending on and if we're getting the value back in that agreement or not. And that's been a big part of it too.
So, John, this is Opal. I'm glad you brought that up because that is one of the things that I've seen is a lot of groups that are out there, right? The hospital or the health system is trying to do a make versus buy decision, right? And it needs to be reviewed on a regular basis. It might make sense to go ahead and have a PSA for your emergency department for a number of years, but the healthcare needs of a community change over time. And so does the agreement still make sense for how that changes, and knowing the information you need to have that make versus buy decision. What if you want to go and have more of an integrated role with other members of your ACO, or you need a regional referral system because the volumes in your labor and delivery department have declined? How are we going to make sure we have complete OBGYN coverage? Because a lot of groups that don't get ahead of this from a strategy perspective and don't have the information to make the make versus buy decision, next thing they know, they're in a situation where they have, you know, 2 OBGYNs who are upset at doing a 1 and 2 call coverage, and you're having to do, you know, locums. And that's an absolute matter of necessity, because you never know when a pregnant mother is going to show up in your ED and have to give birth, and realizing that you don't have the appropriate coverage anymore because you couldn't make a very informed make versus buy decision.
Mm-hmm.
Yeah, very good. Okay, let's switch gears to one that came in that's really interesting here. So this question comes from a participant who has a quality bonus that's built into their RVU model. I'll start with Opal. It says that staff doctors complain there's no ownership on the part of the patient. Are there ways to shift the burden back towards the patient population, or at least have the payers leverage that in some way in the new compensation? I'll start with Opal.
Yeah, so this is one of the things that I, on the physician side of things, is a key area of frustration that I think is, you know, a relic of PQRS, where they came out with so many of the scores that are out there where, you know, the physician says, how am I paid on this because I have no way of impacting it whatsoever, whether or not the nurse smiled at the patient that day that they filled out their patient satisfaction survey, or it was a non-compliant patient, and those different pieces of it. And so one of the things I like to do when developing a compensation strategy is actually work with the physicians for what are the quality metrics that actually make sense for us to be tracking, and use that in my negotiation with actually my payer contracts in how I'm going to get paid for different quality pieces, and trying to make sure that those are simplified, but also what investments do I need to make as an organization? Do I have a patient-centered medical home or team-based care that can help with some of the patient compliance issues, but also to move away from some of the things that the physician doesn't have as much control over, and maybe we pay for that in other areas. Maybe that becomes the nurse's incentive compensation pool with, you know, certain things about patient satisfaction, and the physicians are more based off of the quality metrics, some of them which are going to be led by MACRA and from MIPS perspectives of what can they actually control from an outcomes perspective, and simplifying those quality metrics to be tied to what is appropriate for that specialty, or if it's primary care, you know, what they have available in their office to be able to do that, and making sure as an organization you will go ahead and fund the resources necessary to be able to have everything that is within your control under your control, so that the physicians feel like it's a true partnership. As far as moving the burden to the patient population, in a world of consumerism, that's going to be a very difficult move because the patients are going to speak with their feet and go to either other health systems that have the outcomes that they want or are at the price that they want to be able to pay for. So I would focus on what you can negotiate with your payers, but have it be more physician-driven in determining what those metrics are.
Awesome answer. Neely or John, anything to add on that? We'll leave that one with the compensation. Excellent. Okay, I want to ask one question because we're seeing a lot of questions come in around products. So I'm going to be very direct in this, so everybody buckle up. First to John and then to Neely. Your organizations had a contract management system before you partnered with Ludi. Why did you buy DocTime Log if you had a contract management system? What was missing? John first.
Well, the payment part of it. You know, the contract system took into account terms, expirations, ownership, but it didn't track the actual payments that were going out. And in our case, that was a manual process, either via audit or through our legal team doing it almost monthly to validate that payment matched the agreement. Now, with the system, we're able to produce those reports upon request, and you know we get those quite often, and it can come from various departments. So that was, to me, that was the biggest part that was missing. out of our contract software program that we have, and still have actually.
Excellent. Neely, anything from your perspective? Why did you guys?
I would add we also had, and we still have, a contract management system that does a great job of tracking the contract milestone for renewals and, making sure that we've always got a current contract signed and executed, but it did nothing relative to time tracking. So we had no way, it didn't help us in terms of the operationalization of the contract. It just simply was a placeholder, for the filing cabinet, essentially. So while we had an electronic filing cabinet, it didn't automate anything relative to paying the physician, tracking the time, making sure the duties were matched up to the contract. So that's what DocTimeLog does for us.
Awesome. Opal, anything to add from your perspective?
So one thing that I see is, and don't get me wrong, I love Excel. I am a complete Excel nerd, and so use it for all the time for tracking things. And a lot of hospitals and health systems assume that they can't afford something of this nature. A key thing in physician practices is they have the front desk person call and do all the appointment reminders, thinking that anything that's automated will be really expensive. And one thing that I do when I'm engaged to come in and look at physician practice losses is do basically a time study of how much are we actually spending manual time tracking these things. So if you're doing all of your tracking in Excel and doing it, that is a manual process. And sometimes that is appropriate. You might just you're a small hospital, we employ 4 family medicine physicians, we do not do any medical directorships, it's super simple, they're all on a base salary. Okay, that is easy to track, and the manual hours associated with that is very simple. As you gain complexity and now you have a specialist, or you've changed, or you're now being paid for medical shared savings, right? You're preparing for macro with MIPS and doing advanced APMs, and being able to track that, now it creates more hours. And who is doing that? Is that person? I was in a system that was having to do that actually, where their controller was the one who was watching all the physician contracts, had this massive Excel spreadsheet, was trying to track when contracts need to be negotiated, what were the terms, et cetera, what were the payments, working with her payroll. When you think about the best use of her time and all the other responsibilities she had to the entire hospital outside of just physician spend and contracts, maybe that was an area where automation,
And I appreciate you all sharing that, because I think, as you've said, with fair market value and setting up your contracts right, you can set them up right, but if you don't pay right every time you make a payment, then you're out of compliance. So I think an interesting note, appreciate John and Neely, you sharing your stories as well. It's really about executing appropriately. So we have 2 minutes left. Let's go around real quick. I want each of you to give, one sentence of advice for the group today. If you could offer anything related to a lot of cooks in the kitchen and a lot of people on this process, any advice? I'll start with Opal. You go first.
I would go ahead and start with doing a baseline assessment of where are you. If you can't name off the top of your head who in your organization is overall responsible for this, and it probably isn't your organization's CEO of saying, well, they're bottom line, they're responsible for everything. Who is in charge of that? That should be your first question. After you ask that question, and if you can answer it, right, you need to go through and do an overall assessment of, okay, let's get our baseline of where we are and think about where do we want to go and how are we going to get there, because this is it's too important and too big to fail.
That's right. Okay, great. Let's go to Neely. Any advice you would offer?
I would just say that, and I think really for us, looking at the duties in all of your contracts and trying to identify how you can standardize duties, it makes it so much easier to track like duties across like jobs, rather than each contract having customized duties specific to even sometimes the individual in the role, which may not always be that same physician. And so cleaning up the duties for us has been definitely an operational improvement and has created greater standardization and better accountability for ensuring that the physicians are actually doing the job we've hired them to do.
Awesome. Terrific. John, what about you? Any advice to the team attendees today?
Well, yeah, I think, you know, when it comes to contracts, you got to make sure that they have all the terms, all the agreements, that everything in there is current and accurate, because without it, you're going to run into issues and you're going to run into payments that are inappropriate. And so with us, as we implemented some of our hospitals, the biggest challenge for us is to make sure that data going into the system is accurate and clean, and the contract information is up to date, because what that's going to do then is give our physicians their payments in a timely manner and an accurate manner. And we want to make sure, of course, they're our audience more so than anyone else, and we don't want to affect anything when it comes to physician payments. So that is certainly a challenge. And as Neely said, the duties go with the payments and go with the whole process, and they really drive a lot of things, and it opens up eyes as we look at these.
Terrific. Well, thank you, John. Thank you, Neely. Thank you, Opal. We appreciate all of you attending the session. We will send out a link so that you can hear it again if you like, and we will also answer any questions we didn't get to today electronically. Thank you all for your time.